Hi, everyone. Thank you all so much for coming. We're going to start in about, I would say, 30 to 60 seconds, just to give people enough time to log in, to make sure that there are no technical issues. Thank you so much for your patience. I can see some folks still trickling in, but all right. So hi, everyone, and welcome to our webinar today. Thank you so much for taking some time out of your very busy days to attend this webinar today. Medical Legal Partnership in the Health Centers, Laying the Foundation, Part 1. I am Danielle Rahazasan. I am the project lead here at the National Center for Medical Legal Partnership, and I'll be running technical assistance on this webinar. In just a moment, I'm going to turn this presentation over to Bethany Hamilton, who is our co-director, and also Erin Loubier for further introductions. But first, I have a few small housekeeping things I'd like to run through with all of you. We do have a nice number of participants on this webinar, so you all have joined in muted and will remain so throughout the webinar. However, on the sidebar of this webinar platform, you should all see a list of drop-down options, and in that there's a space entitled questions. So if throughout the webinar at any given time you have a question, please feel free to type it in there, and if it'll come to me, and if it's TA related, I will answer to the best of my ability. If it is content related, I will make sure that it gets to our panelists appropriately. Also, just to let you know that we will also have some time at the end to answer all of your questions, or as many as time allows for. And the audio recording will be made available for participants on NCMLP's website after the webinar concludes. And I've shared with you ahead of time in the chat box what that link would be, how to get to our website. So also in the handouts, everyone should have received a PDF copy of the document we'll be talking about today, which is MLPs and Health Center Guide, along with a handy shorter guide on how many lawyers you need to meet the legal needs of our patients. And lastly, our most recent literature review, making the case for MLPs. If you do have issues opening these documents, please let me know, and we can send you a link to those as well so that you can have them handy. So our webinar today is dissemination of bringing lawyers onto the health center team to promote patient and community health guide, which we also call MLP and Health Centers Toolkit or MLP and Health Centers Guide. So if you hear that, we kind of use it interchangeably. The Health Center MLP Toolkit and webinar series target audience are staff from health centers, PCAs, HCCNs, and MLPs at any stage. This is the first part of a 5-part webinar series, and each presentation will be led by MLP experts from the field addressing specific topics taken from the Health Center MLP Toolkit that we just talked about. So some presentations will include extended time for office hours, and to register for this series and any other webinars by NCMLP, please use the link shared in the chat box, and it will also be available to you at the end of this webinar. All webinars will be recorded and will be made available under the webinar tab of our NCMLP website. Lastly, we do want to acknowledge that this project is supported by the Health Resources and Services Administration, HRSA, and that contents are those of the authors and do not necessarily represent the official views of HRSA or the government in general. So before we dive deeper into the toolkit, I just wanted to briefly reintroduce the National Center to all of you. I know most of you know us and have worked extensively with us, but some of you are also new to this work. So our mission at the center is to help organizations leverage legal services as a standard part of the way that they respond to patients' social needs. You'll see throughout this presentation that MLPs integrate the unique expertise of lawyers into healthcare settings to help clinicians, case managers, and social workers kind of address structural issues at the root of a lot of health inequities. At the National Center, we also provide technical assistance to health centers, lookalikes, PCAs, and health center controlled networks interested in developing MLP. And another one of our objectives is to build and maintain this broad network of stakeholders around the country. So before we talk about the current MLP landscape, I just wanted to launch a quick poll just to kind of better understand who you are here in the audience. Just give me a couple of seconds to launch this for you. All right, so it's basically asking you if you're new to MLP, meaning this is maybe the first time or you've heard about it, but are considering the intervention. If you're planning MLP, meaning that you probably already have an MOU with your partners or have identified a legal or health partner. And if you're currently active, meaning that you're running an MLP currently, and I see that some results are starting to trickle in. About 70% of you have already voted. Thank you so much for that. And then we'll close it. We'll give you about 20 more seconds to respond to get as many responses as possible. Great, so I'm going to close it. Bethany, can you see the poll response here?
I sure can, and we actually have a really good mix. So in the question, how would you best describe the stage in which your MLP is in right now? For folks who would describe themselves as new, that's about 24% of the respondents. For folks who would describe themselves as being in the planning stages, they represent about 27% of the respondents. And for those who are actively running a medical legal partnership, that represents almost half, so 49% of the respondents to the poll.
Awesome, thank you so much.
A really
Bethany.
good mix. Mm-hmm.
So currently, there are about 450 MLPs in 40 United States and the District of Columbia. And of that, about 163 are HRSA-funded health centers, 40 lookalikes, 175 hospitals, including children's hospitals, and 29 from the VA Medical Center. There are also 43 in the other category, and this can include like private community health clinics, for instance. This information is current, as you can see, as of October 2020, but we do know that at any given time, we may have about 20 to 30 MLPs in the planning stage. So the National Center is not a membership organization, so we do not require medical legal partnerships at any stage to report to us. However, we do send out a site survey every year to kind of gather that data, and the next one I believe will come out in February of 2021. So please look out for that just by subscribing to our newsletter or checking back on our website. But in the meantime, if you do have updated information about your MLP, or you're not sure if you responded to the surveys in the past, or you're planning to form an MLP, please contact us because we want to make sure that you are counted. The strength of our research and our ability to advance our work heavily relies on knowing who you are in the field. For example, we do get a lot of technical requests, I would say 3 to 4 a week, where the field kind of asks us where other MLPs are and what they're doing, what populations they're serving, and also to kind of connect. So this is really important for us to kind of gather that data. I also wanted to mention that since there has been a 10 to 15% growth in MLP numbers since last year, February of 2019. So it's indeed a growing movement, and health centers represent the fastest growing sector for MLP adoption across the healthcare system. So why are we here today? We're here today to talk about the toolkit, to go through the first 3 conversations, and which Bethany will really, and Erin will really dive into. But we want to make sure that today we're going to be able to build capacity on integration of legal services to address SDOH needs, and also discuss strategies to guide conversations with legal partners on SDOH needs. Discuss strategies to guide conversations with legal partners on lawyer FTEs, and also briefly go through exploring opportunities to build or contract integrated legal services. And Bethany, can you still hear me? Sorry, I feel like I have some audio issues.
You're good. You're good, Danielle.
Okay, awesome.
I can help. Let us know if you want us to jump in, if your audio is all right. We're in this new space together. We're all working remotely.
Thank you so much, and apologies, everyone. So the toolkit could not have been developed without the partnership and help of our expert panel. And today we'll be joined by one of them, who is Erin Loubier. She is the Senior Director for Health and Legal Integration and Payment Innovation at Whitman-Walker Health. Whitman-Walker Health is a federally qualified health center serving Washington, D.C.'s diverse urban community, with a special focus on people living with HIV and the LGBT community. Whitman-Walker Health has had legal services as part of its integrated care team for more than 30 years. And Erin's role specifically focuses on health and legal integration at Whitman-Walker. She also focuses on the critical collaborations between healthcare services and legal services to promote patient health and wellness by addressing the social and legal determinants of health. So we will have her full bio in the slides that will go out to all of you, in which we will highlight her accolades and accomplishments. And today we'll also be joined by Bethany Hamilton, our co-director at the National Center. Bethany spent her career working at the intersection of health equity and social justice. She comes to us from NAC, the National Association of Community Health Centers, where she led projects focused on expanding Medicaid. And basically, she's done states and health work and programming, and prior to that, also worked in civil legal services. And I will now pass it on to you, Bethany.
Thanks so much, Danielle, and hi, welcome everyone. I have to thank you very much for taking time out of your very busy days as we see what's happening around the country as COVID numbers spike again, just as we're all preparing as well for what is expected to be the fallout from the economic impacts, such as the housing crisis, the fact that folks who may have owned and run very successful businesses, small or large, are once again, as we saw in the Great Recession, facing the very same things that the populations we serve have faced as they fight to climb out of the barriers that poverty places before them. So what we're hoping to do is present some of the mechanics, the tools, and the gears in the machine that we call the medical legal partnership approach. And we know that we do have great variation in terms of who's joining today's webinar. And for folks who will view the recording, you very well may also be at the planning, implementation, or improvement stages. Somewhere along the way, though, you might be asking yourself, for those of you who are in a more advanced MLPs, how do you integrate the legal services into that care delivery model? Let me reemphasize the point that I just made. Even for advanced MLPs who are trying to pivot, to be able to address some of those re-erected barriers that I just noted, you will still be asking, in what way should I be reintegrating or pivoting the legal services into my care delivery model to meet the needs of the population? Next slide, please, Danielle. Why are we asking this? It's because at the bottom line, we're really just trying to make sure that our communities are healthier. I note here healthier patients, but I come from the civil legal services community, and so I know that the patients served by health centers are very well the same population known to civil legal services as clients. But at the end of the day, we are trying to make healthier patients, clients, and communities. Lawyers, we believe, at the National Center are able to help those patients address their urgent social needs that are barriers to health. We believe that MLPs are the pathway to being able to offer legal services at or through a health center or across health systems, and to be able to help folks better access services in a trusted environment, that healthcare environment. And we also believe that health centers are the ones that can best leverage the legal expertise that will come in and be able to shape clinical practices and clinic-wide solutions as well. Perhaps some of you, Erin, will explain some of the work that she's doing at Whitman-Walker Health, have moved from doing just the direct services into some of more of the policy or greater community impact space. And so that's what we mean. And there's also a lot of in between there that I'll explain in a moment. But what we're looking at as well are some of those clinic-wide and community-level solutions that legal services can play in removing the barriers to health. Next slide. Taking a step back in terms of doing some level setting, though, we do have a significant number of folks on today's call who may benefit from just a quick just level setting set of remarks on what is a medical legal partnership. Or perhaps all of us have reached this space where we forgot exactly how to talk about this anymore. So what's a medical legal partnership? MLPs look at basically embedding lawyers into that healthcare delivery model on that healthcare team. As lawyers, we often aren't viewed as a part of a healthcare system or healthcare delivery team. That's probably because we are also stereotyped a bit as adversaries to everyone, right? So there is a lot of cultural change and shifting happening when we talk about medical legal partnerships. But basically, we're saying you're embedding lawyers as members of the healthcare team so that you can create those healthier patients and communities and create that health center workforce change that in a way that strengthens the workforce, and you're improving at the systems level health equity. That's okay. Next slide is cool. How you get it done involves, or it may include, a core set of MLP activities or medical legal partnership activities. You hear a lot of alphabet soup, by the way, as we present today, so I'll do my very best to not just say MLP, but medical legal partnership activities. We've created, as some of you may have seen by looking at the toolkit, or if you've dialed into some other presentations, basically a pizza pie slice here to explain what we believe are some core activities. The first being legal assistance, the more direct services where you're addressing that patient's social needs and helping them, or the folks at the workforce level within the health center, to really be able to reach the top of their license. This is the typical example that you may have heard us utilize, where patient is sitting in the exam room with the physician or the nurse or even a social work provider, and that patient or client is beginning to express to that healthcare system or social services provider some of their problems, but that particular provider cannot address it. If they've identified it as a need that could potentially involve an intervention by the legal services provider, that's what we look at in terms of this sort of pizza pie slice as your legal assistance approach. But as you continue to travel in your medical legal partnership approach into addressing changes at the systemic level, you may decide that your MLP is going to address training for the health center workforce. Everyone from the front desk receptionist who's answering the phone or addressing people's needs coming in, training those folks to better understand how to recognize and refer out to a legal services provider, or you very well may be addressing some sort of, then moving into the clinic level changes, some sort of approach that looks at your flow, your workflow of services. So this is continue to move on, right, into your continuum of change here with your MLP approach. You may, as I suggested, as Erin will talk about with Whitman-Walker, work into your policy change strategies. that may identify, as we found and highlighted on the National Center's website, several health center MLPs that have moved into looking at regulatory, administrative, or legislative policy solutions that address whole entire communities. And that's certainly if you're working in coalitions, it can work outside of just the state and provide some national level systemic policy changes. So these are some core MLP activities: legal assistance, training, clinic level changes, as well as policy change strategies that a medical legal partnership can do. Next slide, please. As we are in this new text space, we're all stuck here. We're going to run another poll. Hopefully it works. This one is more of a pop quiz. True or false? Legal needs are a subset of social needs that have legal solutions. We're just going to run it for maybe 20 seconds here. Legal needs are a subset of social needs that have legal solutions. This is also, if you're like me, your attention span is pretty short sometimes, and you need a little bit of something else that's tactile. You need to click on the poll to like remain attentive. As organizers and panelists, I'm not going to click true or false because I set this poll up and I know the answer. This is really, and no trick questions here, to help keep our attention and see how folks answer. Awesome. So we have the poll results showing up. Thanks, Danielle. And most folks are right. Yeah. So I'd be curious too to see in the chat box, for those who said false, I'm not going to say you are wrong. What I would like to know is why you said that is false. Why, in your opinion, do you not view legal needs as a subset of social needs that have legal solutions? Let me know, since I'm very curious to see. Don't be shy. We'd really like to see where we are, like why that there was a huge percentage difference there. I think it was 75% of people said true, which I would agree, and the National Center would agree that the answer to that is true. We view legal needs as a subset of social needs that have legal solutions, but I'd be very curious to see what folks say in the comment box as to why they may differ in how they are defining legal needs as a subset of social needs. So next slide. Which social needs are in fact legal needs? Let's walk through this. If you're following along and you do have access to the toolkit, by the way, what we did here was we tried to pull some questions, content, and graphics to really help guide you through, with some context, what we're explaining in the toolkit. And to add some additional context, that's where Erin will go into further detail about how this is playing out on the ground. But one of the very level-setting pieces that we wanted to do was make sure that health centers are viewing legal services as fitting within the overall response to the social determinants of health. As we talked about this topic, however, we thought it would be very important to make sure we agree, first of all, on what the social determinants of health are, and then distinguish that from social needs and explain how legal needs are a subset, at least in our opinion, of social needs. So remember, the WHO explains that the social determinants of health really are the conditions in which people are born, where they grow up, where they work, where they live, and then age. Let me just add a note here. I know we have the food desert example as an example of social determinants of health. If we look at COVID-19 as a snapshot for what we already know, looking at age as a social determinant of health, if one was in a nursing home setting, we know that that itself played out as a social determinant of health. And I mentioned nursing home and aging populations as opposed to institutions that may provide a nursing home setting for institutionalized care for folks who may not be of our aging populations group. But then from that, you have social needs. So those are your more immediate individual needs that really manifest themselves for the individual that's being served. In the example on the screen and in the toolkit, using the food desert example, this is where you move into an individual family's needs for example, fresh produce. If that individual and that family may have a condition that requires special foods, for example, a diabetic. I, in fact, had clients like this who were diabetic. They received very limited food stamps, and it was not enough to be able to afford the sort of fresh, healthy foods that one would need to be able to maintain good health for a chronic condition. Then you travel, as I noted, as a civil legal services attorney. Then you travel into the specific legal needs. And I can think of the same clients I had in mind whose food stamps were not maxed out to what this individual was eligible for. And that's where we saw the SNAP benefits, the Supplemental Nutrition Assistance Program benefits, the civil legal services system stepped in to ask that social services system to please provide this client. We have an actual legal scenario play out here, a legal basis to ask for this, but we asked for that individual client to have their SNAP benefits increased, and that should have enabled that person to better control their chronic condition. So next slide. All right. Once you move beyond the basic definitions, the next question, and Erin's going to definitely walk into this in more detail, that you're looking at the people, basically your staffing capacity, and how your different team members, both in existence and the one you're thinking about bringing on, which are the lawyers, the paralegals, the civil legal services folks, how are those different folks able to better address the social needs while working at the top of their license? We say the top of your license, we know there are certifications, we know there are things that others, trust me, a license costs a lot to maintain. So it doesn't matter whether you're licensed or not. What we really mean is, how are you looking at those different individuals as being able to work at the top of their skill set, what it is that their specialization would entail. So still utilizing the family, right, as the example. You see that we look at a family of 4 who might be struggling to make rent. This is the exact scenario that has played out before COVID, exacerbated by COVID, and we hope we're able to get under control if COVID ends tomorrow. Look at the CHW as the example. This is one of the most, I think, because they look very different in different communities. This is, I think, one of the broadest and most varied categories of individuals who have the most access and some of the greatest impact on reaching community members who are patients and clients. This type of individual is the person who can help the patient fill out the applications, complete the documentation, and be able to help that family access benefits, or at least access the health center's case manager or social worker, who will then, perhaps depending on your workflow, immediately spot the need for civil legal services to step in and help that individual, that mom in the example that's on the screen and in the toolkit, better access and take advantage of her rights under the Family Medical Leave Act, as well as any job protections as we continue to note. And then that CHW that's in the community would continue to help them stay on top of whatever additional needs may arise and come up throughout their process. Next slide. All right, so those are the specific examples, and many of you may be thinking, all right, like, is there a way to think about this in terms of like buckets? I know the research community likes to think in terms of buckets, so do I. I'm not a researcher. Several years back now, the National Center came up with what's called an iHelp chart. And in fact, that helped to really like think about this conceptually in terms of like bucketing the social needs, income and insurance. Those are your SNAP benefits, the disability benefits, cash assistance, and health insurance, right? We're in open enrollment period yet again, and folks, whether you're in Medicaid expansion state or not, or you're accessing private insurance coverage through the exchanges, that is one of the buckets in which lawyers can provide additional assistance to the patient population served by health centers. And then you have housing and utilities. Remember, I mentioned COVID at the top of my presentation. I just want to note that it's not just the evictions problem that we see, but we know that utility shutoffs have already occurred and are continuing to occur in this housing crisis. Then education and employment is another bucket in which you can think about the social needs that lawyers can address, as well as legal status, such as veterans and their status related to discharges or immigration statuses, or for folks who are justice involved, they may have a criminal background that involves complete errors, or perhaps if records aren't erroneous, they could use a lawyer's assistance with expungement. And then certainly in the broader bucket, we talk about personal needs or family stability. And so this is where you find issues such as child support, estate planning, DV issues, intimate partner violence issues. These are also ways to think about where lawyers can help. Next slide. All right, so what Danielle and I did was we told you what the National Center does. We talked a little bit about just remember the social determinants of health, the social needs and the legal needs. Now you're ready to build, or for many of you out there, as we saw from the poll, rebuild, improve, or make a pivot to better address some of the things that you're seeing reemerge in the communities around the country. As you think about how to build or improve, what we suggest in the toolkit is that there are a standard set of conversations that you may want to have with your partners. And this is where I'm going to turn to my colleague out in the field. Erin really is one of our favorites, but please talk to us so you can all be our favorites. I say this because Erin and other expert panelists really helped us to harness all of the awesome data you all have helped to create in running and operating your medical legal partnerships over the years, as well as the folks who have come to us for technical assistance to bring all of that data and information together into this toolkit to help all of us build and improve the medical legal partnership approach and address those pressing issues that we're facing today. Erin, I'm going to turn it over to you, and thank you very much for helping us walk through the conversations to lay the foundation. Thank you.
Thanks so much, Bethany. And I couldn't be more thrilled to see Bethany as the new co-director at the National Center. We have a long history from her time at NAC. She's an incredible leader. So I'm really thrilled to be here and appreciate the opportunity, to talk about these conversations and building strong medical legal partnerships at health centers. So if we want to go to the next slide, I think we can even go one more. I think, Bethany and Danielle, in introducing us, really highlighted Whitman-Walker and our history. The one thing I would point out about our 30-year history is that we started, providing legal services because legal services were the only treatment option for people who were dying from AIDS. There really wasn't good medical treatment. And so, there was a recognition that lawyers were easing different issues that people were facing, both structural barriers and other things. So whether it was fighting discrimination in healthcare, securing disability income, or insurance coverage for particular treatment, these were interventions that were really the things that were helping provide care on a care team way back in the 80s. And so that history really, I think, is unique. And we then were part of this AIDS service organization that then became a federally qualified health center. And I share that because, part of that 30-year history is that we have had a lot of trial and error at ways, to use lawyers on a care team and work to overcome health inequities and address structural barriers. So my remarks today are, kind of highlighting some of the ways that we have shifted or evolved over time, and how those apply to some of the conversation starters, that are part of this guide for all of you looking at either any part in the planning, implementation, or, envisioning stages of your work. So this is, yeah, perfect. So I'm going to start just, with building capacity to integrate lawyers on the team. And this really is more than just, I want a lawyer on, on here, or, what is that going to look like? This really is our model of integrated care. And you'll see at the center with the heart in the middle, that's the patient. And the way we think about it are that all of our services are about working to meet those goals that, that Bethany highlighted about the why you'd want to embed lawyers, healthier patients, stronger health center workforce, improved health equity. And I would just say that the couple of things that are kind of hallmarks on those 3 points to Whitman-Walker's model are that healthier patients are really more engaged patients with a better patient experience. So those are things that we focus on about how we're going to, do that work and how we work together So you see how all of those lines connect all of us, and there are all these things. And the goal is really we are navigating that patient, not that the patient is navigating through us or navigating the services that we can provide. And that we recognize, that this is going to take a robust set of, workforce specialists who can address and work at top of licensure, but on the things that they may be able to most impact. The second around, kind of workforce is that the deeper connection that we get to patient care issues and the way that the workforce itself garners really deep respect for the other members of the team, which ultimately then impact morale, efficiency, better workflow. And then the last is really, moving upstream to remove structural barriers that impact access and engagement, and seeing the ways that specific population characteristics may be opportunities for unique engagement based on different workforce specialty. So I'm gonna share a few examples of that in a second. And if we want to go to the next slide, I thought I'd just share this. That's a bunch of our staff, and this is really how we define or see the legal services role on the care team to address health harming legal needs. The first is really just providing direct service and counseling and problem solving skills. Then the second is navigating. Our legal services team is also has our eligibility and enrollment, our insurance navigators as part of the team. We are a broad team of kind of paralegal and frontline staff who are doing eligibility and enrollment, all the way to lawyers who would handle denials, policy, advocacy, and other things. So the insurance navigators are also our screeners for the legal barriers to accessing care. And so we see people as the way that we screen things. Those are folks who have a lot of the information and issues that we could then identify and address as lawyers. And so they are part of our frontline, team doing that. We also then use kind of the empowering clients and other service providers through Know Your Rights, curbside consultations. You're going to hear a little bit more about that in the presentation. And then the last is taking all of the different information that we get from our representation interaction with clients to look at the local and national programs that clients rely on and work to remove systemic barriers or to improve the systems in which they operate. So we have another poll. If we want to go to the next slide. How is your MLP addressing social determinants of health problems? So there are really three options or three types of ways. One is an intervention that's all patients, specific social needs. The second is specific patient population, but all social needs. And then the last is all patients, all social needs. So when you're looking at how you're defining what your MLP is going to address, which do you fall into? And then there's another category if you're doing a combination of these, these different options. So we'll just take 20 seconds to give you a chance to jump in and look at that. All right, let's look at the results. So this is really interesting. It's sort of evenly just divided among all of them. So we have, we have kind of a really nice distribution of people using these three different approaches, and then probably a combination of those approaches as well. So let's sort of talk through Whitman-Walker uses all three of those approaches and has looked at that at different points over time. So I'm going to highlight a couple of each of these in what we've done just to highlight. So if we go forward another slide, that would be great. Yep. All right. So the first thing I'm going to just highlight is, we have modified and changed and looked at, and we're going to highlight a chart that shows the different legal services that we provide to patients. And, we grew out of, our focus on people living with HIV, and we now serve any patients, who are part of the health center. We are disproportionately, LGBT focused and people living with HIV, but we address any issues that, that our patients have. We have defined that though in kind of a lens of what is impacting people's access to care and overall healthcare needs. And so you'll see in a few minutes when I show you the list of things that we work on, there are a couple of things that are notably not, on that list, and I'll talk a little bit about that. But we actually had some really interesting data as we were looking at these different approaches over time and what we were addressing and where patient populations were potentially struggling with overall engagement in the health center. And one of those examples was, we're an LGBT health center, and we had about 250 trans-identified patients in care. And we thought, there's a lot more trans-identified or non-binary folks in the city. Why are they not choosing to come to Whitman-Walker? And we started to think about a lot of different things, like what does that engagement look like? What are the needs of the community? How do we kind of meet people where they are? And one of the things that started to come up was you need an ID to get to do anything. You need it to get a job, to go into a government building. Many other buildings require that, to go to a bar. And one of the first things that many healthcare providers ask when you register as a patient is for your ID and your insurance card. Well, we have this robust insurance navigation team that helps people get insurance or talk about cost of care, but we recognize that we actually weren't necessarily addressing this issue of the identification, which was a potential barrier to trans and non-binary folks. And so our motto is we see you, and the goal is really to see the person first. And so we started to look at that, and we created a name and gender change clinic that, and we can go to the next slide. I think it might be too forward. Yep, one more. And we basically started helping people update identity documents. And so this name and gender change clinic was launched in June of 2012 at about 250 patients in medical care. And we have brought in lawyers, we served pizza. It was an opportunity for people to engage, with our staff and with volunteer attorneys and each other. And people, and we would say like, hey, do you know we have medical services and behavioral health services and dental services here? And people were like, you do? And then we'd update their documents. And basically what happened is that people then felt they could take the step and connect, to these other services because they had a trusting, interaction and a really positive experience doing the thing that actually was probably preventing some of those interactions first. Within 4 years of that, we had over 1,500 clients in medical services, and now we have over 2,000 clients. And so typically when we think of MLP as an intervention, we often think of it as an engagement after someone is a healthcare patient. We sort of flipped that on its head and decided, like, we aren't seeing certain patients in our health practice. Like, why aren't we seeing them? And we use legal services and the need to reduce structural barriers as the gateway into these other services. And so I think one of the things, for the conversation openers is really like, why are you doing this? One is to hit all of those 3 points that, Bethany and I have highlighted. But I think the other is you're trying to figure out what is the intervention that's going to be most effective to, engage and increase someone's ability to be healthier and have better health outcomes by reducing the barriers that they may have faced. The other things we do for this patient population now are there are a lot of issues around insurance coverage for gender affirming care, addressing transitions at work, workplace hostility, and we help navigate those things. And so this really was, I think, one of those hallmark ways that the legal intervention can be the gateway. So if we want to go to the next slide, I want to just highlight a few more things, and then we really want to hear from you some, questions that are burning for you. So we keep going. So how many lawyers do we need to meet whatever identified goals that we may have at the health center level? And so, you know, what we have really focused on is like the data and observations from teams about places where they have not felt equipped to address what patient issues are arising. And those data points and even just observations or hypothetical, you know, or those conversations around places where they've struggled, those are often the best ways to figure out, like, where is the workflow getting held up and where are the places where people feel not qualified to help. And so the questions that I like to ask teams are like, where are you getting stuck? Where are you disproportionately spending time on patient care issues that you don't feel you can address? Those are typically really, really important places to then focus on what an MLP lawyer may be able to do in both improving the entire landscape. So these factors are really highlighting a few things about how we use time and how we judge capacity of an MLP lawyer. And I would just say a couple of things. Patients definitely almost always have more than one issue. We average somewhere between 2 and 4 legal issues per patient. The more complicated the issues, the more time it takes. And that's why we have this continuum of paralegal services all the way to attorney services. And that legal is like representing someone is really just one function, right? We are expecting or wanting other ways that a lawyer is going to enhance the care team, from training and training. I like to say it's not necessarily you're training someone else, you're really developing or broadening someone's capacity to identify or triage issues that may be happening. And then the other is really the support for the team around trying to help solve those problems, and then policy level issues. So if we go forward again, I just wanted to highlight a couple of things. So if you look at this, it's a list of what legal services Whitman-Walker provides. And this is our 2019 summary. We did about 4,500 cases for 2,600 clients. That was done by a team of roughly, let's see, it was a paralegal and 8 attorneys on the legal team and a team of 12 insurance navigators. That's a lot of people. And you may be thinking, oh my goodness, that's a lot of cases and clients, or you may look at that number and think they couldn't do more. Oh my goodness, why not? I will just highlight that, we are an incredibly busy office and we handle many issues. Some things are not counted as cases, like curbside consults or, places where it's a brief interaction with clients. But this is really like what we were able to accomplish. And these are the kinds of legal issues, that we did: public benefits, insurance issues, discrimination, workplace rights, immigration, estate planning. You may note that one of the biggies that is often tackled in MLP is not on here, which is housing issues and landlord-tenant issues. Part of that is our history and the history of DC, where there were really established legal services providers who did those issues. And so we didn't want to in any way, to try to get funding or other things, that we would be seen as competition. The other is our worry that like our focus is on healthcare. And even if we threw all of our resources there, we saw the really big, systemic issues, and we wanted to ensure that people, were addressing that, in another way. And then if we skip to the next slide. So this is our insurance navigation team, and this is that kind of frontline staff. They did about 3,000 of those cases from before, and they're really doing all of the different eligibility enrollment, and there are screeners for these other legal issues. So the last thing I just want to highlight, I have 2 more points, and if we go forward to build it or contract it, we can go one more. Thank you. So when we're thinking about, how you actually how you actually engage with lawyers on the team, you know, the options really are that you hire the lawyers as employees of the health center, the build it as a direct service model, or that you contract with another legal services entity in the community, you know, to provide a certain amount of legal services to your health center. Whitman-Walker is the build it model, and we've been the build it model the whole time. And you know, and we are all employees, and there are lots of pluses around the things that have been highlighted here: alignment, control, you know, really being very integrated into operations. But if you are starting out, or you're newer to this, or you don't have yet size and scale, you know, one concern is hiring one attorney who's kind of on their own without infrastructure that may come from, you know, a legal services organization is going to be really hard. And so I just point out really that big picture, we're trying, you know, to ensure the success of, you know, whatever we build, and that we often, you know, have bigger, you know, it's sort of like we have way more that we want to get done than we may have capacity or size or scale to do. And I think one of the hardest pieces in these conversations is, you know, is not the sales pitch or the people, you know, really understanding the need for an attorney on the team, but potentially that the expectation of what one attorney may be able to do is way higher than what it may be. And then people see it as being disappointing, or that it wasn't successful, when we just may not have scaled it right. And so those things that we had a minute ago, just about, you know, where we were talking about the different approaches of, you know, is it all patients, all kinds of social needs? Is it, you know, population specific? There is a synergy between that decision for your organization, how much you can afford in terms of legal assistance, and then this piece about the benefits of whether you build it or contract it. And so there's kind of, I think, a little bit of alignment that needs to happen with those three pieces, or you potentially are setting yourself up and that attorney up for disappointment, you know, and disappointment within the team itself, because you're trying to build the team's reliance on each person's specialty skills. And that means that they're available, you know, throughout to, you know, to refer, you know, for those different things. So I'm going to conclude, and I think we're ready for question and answer. And I look forward to hearing more from all of you. Thanks.
Thanks, Erin. So hi again, everyone. This is Bethany again. And I know, Danielle, there was a question sent to us about one of the quick little musings in a hypothetical that was posed. Do you mind reading that question out, Danielle?
Yeah, so it's from Danielle Bernard, and she was asking, are there different levels of SNAP provided if a client has a special need like diabetes?
Yeah, great question, because I very quickly noted in just using reflections on past work that I did that I had a client who was a diabetic, and no, I don't know that there are different levels of SNAP. The problem was, and certainly not based on chronic conditions or conditions at all, the problem was with that client, and this is the point of legal services stepping in, and then looking at the top of one's license or training or skill sets and title and such, is that individual just simply hadn't filled out the paperwork correctly. This is well over 10 years ago, by the way, in 2008 or 9, I believe. So bear with me. Client didn't fill out the paperwork correctly, didn't, I think, have the right income information provided, and didn't max out. I think it was around $200 a month at that time for that state in terms of SNAP benefits. And so that certainly was a barrier to being able to afford the healthier foods that were needed to be able to control that chronic conditions. And so I saw Erin noting that, no, SNAP really hasn't changed, not in that regard, that we know of, not based on chronic condition level or levels based on chronic condition. So no, that's the point of really ensuring that that individual who might be explaining to that physician who's recommending, or to that nurse, or to that dietitian, for instance, or social worker, that they just cannot adhere to a specific diet, asking the next question, why? And then being able to, if you're trained on the clinical side, potentially, I'd be able to identify that it's potentially a legal need with a legal solution. And it's not necessarily the case that I had to help. It very well could have been one of the other individuals there at the legal services organization where I was that could have stepped in to assist. Thanks, Danielle. I have a question to pose to Erin, and then we'll look out for any additional questions or commentary that might come in. Actually, it looks like we have another set of questions. Let me preface this by saying, in the toolkit and in future webinars and learning collaborators that we'll really discuss some of the weedier topics around financing, funding, coming up with the actual agreements and the MOUs to put in place to build and sustain the medical legal partnership. And so I think one of the questions that came in, what are some ideas for pursuing funding to support MLPs? Erin, that goes to one of the questions I think I had for you. Based on your empirical knowledge now, can you share, what are some of the biggest roadblocks or challenges to starting or operating an MLP? Is funding one of those bigger challenges? And do you have any, either it's no, or do you have any thoughts on that audience member's question?
So I think funding from the healthcare side is often, a big barrier from kind of leadership buying in, like how much is this going to cost? And then wanting a really clear idea on what the return on investment will be for investing in this, like how will it save us money somewhere else, or how will it, help us meet patient outcome data. And I think the challenge there is that initial jump to decide it's worth doing is going to have a financial investment that may be significant, and that the return on investment is, you will likely see lots of things, initially, but the return on investment is a long-term investment in, being more upstream and, creating a workforce that really functions, using specialists in the right way, and that, the health outcomes, we don't have great ways to necessarily measure it was this intervention alone that did it. And so we've really moved, when I showed you that integrated care model, we have really tried to avoid and it was the lawyer who did this, or it was the doctor who did this, or it was the care navigator who made the difference. We see it as any of the things that happen that make somebody healthier, or we've solved a problem, as a success of the team, to try to avoid at some level, the parsing out of the return on investment. And that may be a frustrating answer to many of you on the phone, and I'm sorry for that, but I think it's missing the, sort of creative and innovative, ways that this intervention may actually yield lots of different things that you can't even articulate until you're kind of there.
Thanks. And I know we have some other questions that came through. So Erin, I want to take another stab at trying to, number one, let the audience know that some of the questions that are coming up, I see, about data privacy issues, those are certainly questions that Erin or other MLP folks who are well advanced in their timelines and development of medical legal partnership have addressed, and that the National Center also has an issue brief to address some of the, separate from our toolkit, to address some of those very weedy concerns related to everything from malpractice and representation to data privacy issues. So I'd encourage folks to not just look at the resources that we've highlighted on the screen, but also take a look at our website, the webinars link, as well as our resources link that are up on the screen. And taking liberty and stealing some of Danielle's closing remarks here to just be able to address some of the other questions that came up in the chat box. For the folks who are addressing COVID-19, I'll use this last few minutes to just ask you, Erin, have you all in the DC area at Whitman-Walker seen any need for changing or pivoting some of those conversations you're having regarding your MLP approach to better address or differently address the COVID-19 exacerbated issues?
So I think that's a great question. And I think, we certainly are seeing the incredible health disparities in, who's impacted and like the severity of impact of COVID-19. I think we as a health center have faced, even our pivot to telehealth, we have faced really serious changes in the volume of encounters and, funding changes. And so I think, from a big picture look at how an integrated care team and how having lawyers on the team, is helpful. I think it's hard to plan and not be in the immediate, we are running frontline COVID clinics and, trying to address those issues. I also think we've seen a lot of people who are not connected to a medical home through COVID-19. And so we are testing lots of people who have not been connected to us previously. Some of those people are looking, to connect and that, or have questions about return to work after a COVID-19 diagnosis, or they're frontline workers and have conditions. And we've helped a lot with the counseling around know your rights and workplace rights issues and leave related challenges. But I think that there's a really interesting future that we need to kind of get past the immediate crisis mode to how does this illustrate health disparities in a unique way, and what way can the lawyers, potentially be addressing those structural barriers and promoting health equity on a population level. And so that, I think, are a couple of the things that, we're looking at and struggling with, as I imagine many people on the call are as well.
Agreed. So I know we're at the top of the hour, and I'm going to first thank both Danielle and Erin and the audience members for really joining us today, as well as folks who will be viewing this webinar. And I know we received a lot of other questions that came in the chat, so I'll just note before asking Danielle to close us out today that thank you, audience members, for sending us those questions and participating in today's webinar. We'll actually attempt to answer some of those in the follow-up. And so feel free, as Danielle closes out, if you did have a question, come in, slip it into the chat box, because we'll actually attempt to answer in the follow-ups. Thank you all for joining today, and I'll turn it over to my colleague Danielle to close us out. Thank you again, Erin.
Thank you.
Yeah, thank you, everybody. Thank you, Erin and Bethany. As you can see up here, we have the contact information if you have specific questions for our panelists. And also, I want to remind everyone that the copy of the recording of this webinar, as well as a PDF of the slides, will be made available on our website, which we shared with you through the chat. And yeah, thank you again for coming, and we hope to see you on Laying the Foundation Part 2. Goodbye, everybody.